When a patient needs to rule out a pulmonary embolism, a CT pulmonary angiogram is the standard choice. But if that patient has a severe contrast allergy or a very low glomerular filtration rate, CT is contraindicated, and we have to rely on nuclear imaging. Nuclear imaging relies on deploying targeted radioactive agents to exploit specific microscopic bottlenecks in human physiology. To read these scans accurately, we have to decode three distinct mechanisms of radiotracer localization: mechanical trapping, compartmental containment, and biochemical mimicry. Every tracer operates under strict physical and biochemical rules. Knowing exactly how and why a particle binds, blocks, or clears is the only way to accurately interpret the resulting images and identify artifacts that might otherwise look like life-threatening pathology. We have to reverse engineer the tracer's specific mechanism of action to visualize exactly what is failing inside the body. We begin with mechanical trapping, used in the perfusion phase of a VQ scan. The tracer here is Tc-99m macroaggregated albumin, or MAA, and its entire job is to physically lodge itself inside the pulmonary capillary bed. The anatomical bottleneck we are targeting is the normal human pulmonary capillary, which has a diameter of approximately 10 micrometers. This diagram illustrates the size constraints. Manufactured MAA particles must be greater than 10 micrometers to wedge here, but less than 150 micrometers to avoid occluding arterioles upstream. The dose of 500,000 particles sounds massive, but it safely occludes less than 0.1% of total capillaries, leaving respiration unaffected. When the tracer behaves as expected, it lights up the entire lung field with a uniform distribution. If we see this even spread, we can confidently exclude a pulmonary embolism. The success of the perfusion study relies completely on the physical dimensions of the manufactured albumin perfectly matching the microanatomy of the patient's lungs. That structural logic fails when a patient has altered hemodynamics, specifically a right-to-left shunt, like an atrial or ventricular septal defect. In a right-to-left shunt, particles bypass the pulmonary filter, flowing directly into systemic circulation. They mechanically trap in wrong organs, lodging in capillaries of the brain and kidneys. For these patients, total particle count is drastically cut to between 10,000 and 100,000. But there is a vital clinical rule. While the physical number of particles drops, the total radioactive dose of technetium must remain exactly the same. If you reduce the radioactivity along with the particles, the resulting study will be non-diagnostic. Another breakdown of the mechanical rules happens prior to injection. If a technologist accidentally draws blood into the syringe, the MAA quickly aggregates into massive clumps. On the scan, this appears as large focal hotspots scattered randomly across the lung fields. Abnormal uptake outside the expected distribution is never random. It maps exactly to the altered physical pathway of the microemboli. To evaluate the ventilation phase of the lung, we abandon mechanical trapping and switch to compartmental containment using a radioactive gas, Xenon-133. Xenon-133 possesses two key physical properties. It emits a low energy of 81 kiloelectron volts and has a physical half-life of 5.3 days. This graph plots xenon's slow physical decay against its sharply dropping biologic half-life, as the patient simply exhales the gas. This rapid clearance forces a highly compressed timeline, divided into three rapid blocks: wash-in, equilibrium, and wash-out. Xenon's chemical properties can also highlight incidental pathology. Because it is highly fat-soluble, delayed washout over the right upper quadrant indicates hepatic steatosis, as the fat in the liver stubbornly retains the tracer. An alternative tracer, Tc-99m DTPA aerosol, physically coats the branching airways rather than acting as a true gas. However, because its emission energy perfectly matches the technetium used in the perfusion scan, you cannot perform quantitative differential studies if you combine the two. Mapping compartmental ventilation is an exercise in strict timing. It requires capturing data in the tight window where the tracer's physical decay limits overlap with the patient's biological respiration rate. Our third localizing mechanism moves entirely away from physical flow and into cellular interactions. This is biochemical mimicry, demonstrated by gallium-67. Gallium has a complex physical profile. It decays via electron capture with a 78-hour half-life, and it emits gamma rays at four distinct energy photopeaks: 93, 184, 300 and 393 kiloelectron volts. Its diagnostic power comes from chemical deception. The body treats a gallium +3 ion exactly like a ferric iron +3 ion. Gallium locks directly into circulating transferrin proteins, hitching a ride to lactoferrin-rich zones of rapid cell division and active inflammation. The challenge is that this targeting is highly nonspecific. Gallium eagerly lights up an infection, a tumor, or acute respiratory distress syndrome with equal intensity. Interpreting it requires a completely different analytical approach. Gallium imaging abandons the physical constraints of size and flow. Instead, it hijacks the body's own microscopic iron transport pathways to uncover hidden sites of inflammation. To extract a specific diagnosis from a nonspecific tracer, clinicians evaluate the geometry of the uptake. We look for established structural patterns of accumulation. For example, gallium is used to evaluate active sarcoidosis. The clinical standard for active disease is observing pulmonary gallium uptake, graded significantly higher than surrounding soft tissue. This schematic demonstrates the classic lambda sign. We see intensely hot spots in the bilateral hyla and right paratracheal node, forming an inverted Y shape. This is frequently accompanied by the panda sign, where tracer heavily accumulates in the nasopharyngeal region, parotid glands, and lacrimal glands. A definitive diagnosis in biochemical mimicry depends on the specific anatomical geometry of the tracer's accumulation. Whether we are measuring mechanical flow, compartmental gas exchange, or biochemical mimicry, the goal is always to triangulate the exact point where normal physiology fails. This split-screen logic model shows the core of a VQ mismatch. If xenon gas successfully fills the compartmental alveolus on the left, but the MAA particle flow is abruptly blocked in the capillary on the right, a vascular obstruction like a pulmonary embolism is definitively proven. Similarly, seeing the combined panda and lambda signs on a gallium scan confirms active granulomatous disease, because the radioactive iron analogs are actively being sequestered by macrophages gathered in those exact nodes. These radiotracers act as active probes, rigorously testing both the mechanical and biochemical limits of the patient's physiology. In nuclear medicine, it is the specific physical dimensions and biochemical constraints of the radiotracer itself that render otherwise invisible pathology visible.